Well, thank you very much. It's a pleasure to be here with a nice audience and some of the faculty. I actually trained with Mike Bacharach here. That fenestrated case you showed looked familiar. I think it might have been the fellow at the time. And so I've been in Colorado Springs now for 2.5 years, and we've seen several things here today. We've seen how to use a CAT scan to plan your intervention. We've seen how to select who to refer for an open intervention, who to refer for an endovascular intervention. We've seen the use of periscopes. We've seen some tips and tricks on how to manage endoleaks and some fenestrations. And so I want to disclose right now that I do try to follow the IFU as much as possible, but occasionally you just can't do it. You don't have the luxury of the time or the situation or some anatomical constraints. And so I'm going to show you four of the most challenging cases that I've had in the last couple of years of my career here. First one is an 80-year-old woman. She lives independently. She has a 6.5 centimeter AAA. She had a recently perforated gastric ulcer and a couple of recent episodes of small bowel obstruction that were resolved with medical treatment. On the top of that, she has COPD, uses oxygen, but she's a little lady that's very nice and gets along really well by herself. As you can see the anatomy there, the aneurysm is juxtarenal. There's a severe neck angulation, and the iliac arteries are small. And she has a narrow distal aorta. So she has pretty much every challenge, right? She has a challenge of proximal seal, delivering the system, and accommodating probably a modular bifurcated device would not be ideal in this patient. So the solution that we came up with was to utilize a combination of two endografts to remain within the IFU. So we used an Endologix unibody and a fenestrated device commercially available for this patient. During the procedure, there were a couple of challenges that we had to face. The first one was the small iliac vessels. We had to deliver the Endologix device carefully with a brachiofemoral axis, and then we had to post-dilate both of those iliac vessels. We use fusion imaging technology, and then as we advanced the fenestrated component, we had to actually anchor down one of the limbs of the Endologix device with a balloon so that it wouldn't migrate in a cephalot fashion. So you see right here how both renal arteries are cannulated. The device is aligned as best as possible, again with the aid of the fusion imaging technology. Once it's deployed, we advance the sheaths through the fenestrations into the renal vessels and post-dilated the proximal component. You see there one of the renal arteries. The second one, everything looks really good. We post-dilate the junction between the two devices, and we have an endoleak right there. So we weren't expecting to see that, but you can also see that the suprarenal stent at the bottom of it is kind of constrained. So we recannulated one of the renal stents to protect it and post-dilated that once again. And on the 7-month post-op CT scan, we noticed no endoleak. The renal stents are widely open, and the aneurysm started to decrease in size. Second case, this is an 80-year-old man
Can I interrupt you for a quick second? There's one quick question on that. These are great. It's a great case. I think maybe we'll just on each one, since we're at the last. So my only question to you is, and that's a very clever solution. I've seen some other people use that, but any concern, or have you seen any leak between those two stent grafts, since one structure has they have the flipped
we actually bridged, I didn't mention this, but we bridged, then relined the AFX again with a TX2. So the majority of it, right down to where the aorta is really tapered and everything's hugged closely together. And sorry, I didn't mention that, but yes, that was a consideration.
So if anyone's not familiar, the AFX graft, the skeleton stent is on the inside, the graft is on the outside, and it's not tacked down at every uniformly. Whereas most of the other, including the Cook grafts, the stent is on the outside, the graft is on the inside, and it's all sort of sewed down to each other.
Yeah, talking about an exoskeleton versus an endoskeleton with the Endologix device. And so relining it, connecting the two pieces within each other avoids that, I guess it would be a type 3 endoleak.
Thanks, I'm sorry to interrupt you.
No, that's great. The second case, this is, again, an 80-year-old man with severe COPD, severe scoliosis, and some congenital spine problems with chronic back pain, CHF, 5.7 centimeter AAA, and right leg claudication. But other than that, I mean, the man is actually very functional. You see again his anatomy, again with the scoliosis goes hand in hand with neck angulation. He has an accessory renal artery, and he has a severe iliac stenosis on the right side. So with him, we noticed that he had the accessory renal artery was probably not going to be an issue. As you can see, it has a tight stenosis in that area. Again, we used the imaging fusion technology in this case. The neck is long enough, but it's just angulated is the problem. And with this patient, we actually had to do again brachiofemoral access to get across that right iliac stenosis to deploy the main graft. Well, we have this, and actually this image reminds me of the Heisman. You start celebrating, but then you see this endoleak around the outer curvature of the device. So there's actually a good match, but there's some bird beaking that you can't really see. It occurs sort of in a dynamic fashion. And other than that, the whole graft fit in pretty nicely, but we decided to use the Aptus endo anchors in this case to tack down that bird beak, which occurs due to the angulation. And after deploying these, the endoleak resolved. But here's one thing to remember. We always like to remove all the stiff wires and leave only catheters and do the completion angiogram. And you can see there how the iliac stent on that side is crimped. Had we taken out all wires and catheters, we'd probably not been able to get back through it. After post-dilating that, it looked much better. So that's one thing that we like to do, and that I unfortunately learned the hard way in the beginning of my career. 6 months later, the patient has no endoleak. The aneurysm is 5.2 from 5.7. His GFR was unaffected. He has no claudication. His ABI is 1.0. And this is probably the most challenging case I had in the last years of my career. And it was a challenge in every aspect of deciding what to treat first and how. This man is 75 years old. He has a history of chronic back pain, and now he has the new onset of upper back pain. His COPD, coronary artery disease, history of smoking, and he was referred first to the cardiothoracic surgeon across the hall from my office with the upper back pain because they had found a 4.5 centimeter ascending aortic aneurysm. She saw him, decided that had no acute indications for intervention, but she sent him over to me because he had a 5.3 descending thoracic aneurysm and a 5.4 centimeter AAA with a type 1 endoleak that had been fixed years previously outside of town. And so here's this patient with his new unfamiliar back pain, his upper back pain. I examined him, and his abdominal aortic aneurysm is easily palpable, but is not tender. It had expanded about 3 millimeters in approximately 6 months with type 1 endoleak. But then he tells me that his father died of a ruptured thoracic aneurysm. And you can see here the ascending is 4.5. I know that's kind of a weird view of the descending thoracic, about 5.3, 5.6, obviously, some tortuosity. And then you see the 5.4 infrarenal clearly with a blush in there. So which one do you fix first? Another note here on the anatomy. He has 2 centimeters between the renal arteries and the SMA, and both hypogastric arteries are occluded. One was occluded on purpose, and the other one, I assume, was already occluded at the time of the original intervention. So I wasn't sure what to treat first. I figured that I could order a Z-Fen for him and do what I did in the first case that I showed you and fix the type 1 endoleak. So I immediately placed the order, but even if you put on rush, in my experience, it takes up to 4 weeks, 6 on average. So I admitted him the next day, and we did the TVAR. Obviously, we put a lumbar drain, kept him for observation in the ICU. The pain subsided, but over the 24 hours later, the pain increased. He gets another CT angiogram. At this point, it's late at night, and there's no change. So we continue observing him 48 hours after the TVAR. The aneurysm, the infrarenal abdominal aortic aneurysm is ruptured. So now what? Now he's hypotensive, he's got bad abdominal pain. So now I'm beating myself. I wish I had done a homemade fenestrator for him or offered him an open repair, but did not. So quickly, my partner and I took the patient to the operating room. I got access from the arm, put in both sheaths into the renals. She had a balloon down below the renals to occluded, and we deployed these with a cuff, a Cook cuff, and it looks great, right? No leak, perfect. So the pain resolves. I go to my wife's delivery. My daughter was born 1 year ago, actually. I talked to this patient last night, and he's doing great. And but you know, then he gets another scan, and he has pain again, and he has a big leak again. And now the aneurysm is actually bigger. It's from 5.4 to 6.3 by 6.5. Gosh, now I'm beating myself. Now I have to deal with an endoleak that's coming in from the gutters, and you can see it right there along the edges of the along the inner curvature. So we go back into the operating room immediately, quickly regain the access. Actually had been very easy the first place. And we put balloons back again, post-dilate, hoping that it was a matter of not expanding sufficiently. Maybe that the cuff had collapsed or something had changed in that situation. But after aggressive dilatation, it did not work. We put a Palmas stent, hoping we would be able to mold the Palmas stent around the balloons inside the viabonds, but it did not work. So there's a persistent gutter leak that you can see right there. So, you know, now you're 2 hours into it, your anesthesiologist angry at you, and so I got this idea that I figured I'll try to cannulate that gutter and see what I can do with it. So I used a 150 centimeter Navicross, an Advantage Glide wire, and 90 centimeter shuttle sheath, and I get into the gutter and I get into the sac. So packed a bunch of tornado coils in there, packed them really tight, and his pain went away. The aneurysm, days later, before we discharge him, he's already betrayed me twice, right? So I get another CAT scan before we let him go and find out that he has a type 2 leak. And so, fortunately, my interventional radiology colleague he's outstanding. He has outstanding abilities at doing type 2 endoleaks. We did a translumbar puncture, and with the guide of the tornado coils in there, he deployed a whole bunch of onyx, and it worked perfectly. 3 months later, the aneurysm was reducing in size. And 8 months later, you can see nice nephrograms in there. There's no compression of the renal stents. The starburst effect, unfortunately, from all the onyx and coils, but the aneurysm that was up to 6.5 there is practically not there anymore. Of course, this demands lifelong surveillance, particularly with other aneurysms and the concept of endotension that was mentioned earlier. But here's the case 4, and again, this is a 66-year-old man with severe COPD, stage 4 chronic kidney disease. He previously had an AUI in March of 2014 by one of our referring docs out in the rural community out west in Durango. And he calls me and he says, you know, this guy has a rapidly expanding sac at 7 centimeters. It was 5.6 when we did it in 2004. I can't figure out what's going on. We did an AUI because he had an occluded left common iliac and a previous fem-fem bypass. The man had a history of blunt abdominal trauma in the past, you know, mountaineering, which is popular around here. And he has several episodes of small bowel obstruction and occluded celiac trunk, probably from the diaphragmatic trauma back in his youth. So the guy comes over to Colorado Springs. I think it was by ambulance, so 5 hours away. And they send me these images with the patient. So they did an angiogram on him. Well, there's no leak that you could see. But when you look at the CT scan that he had with no contrast due to his CKD stage 4, you can see there's practically no wall apposition in that area. So that was not the only problem that he had. We had to then obtain a CT scan with contrast to figure out what was going on. You can see he had a really tortuous and small renal artery on the right side with ptosis, really thin man. There's infolding of the suprarenal stent in this case, and he has a high-grade renal stenosis on the left side. So now this patient is admitted to my clinic. I don't have access to any of the fancy P-branch devices, but I've seen them, and fortunately I trained with Gustavo Ulrich and came up with this idea through the grapevine and talking to several people. Basically, the P-branch is an AUI that has been kind of modified. So the design that we made in this case was take an AUI, which is a 36 by 127, And the patient had a shaggy aorta, so the plan was to create first a landing zone with an alpha thoracic Cook TEVAR, basically. We lifted the branches, in this case, to force that SMA stent to stay open, which is the most concerning one. We sewed markers around it, and these are Dacron grafts, which are 6 millimeters in diameter by 2 centimeters long, each one of them. We used peel-away sheaths to get everything back into the delivery system. We did the TEVAR the regular way and try to post-dilate that suprarenal stent that was infolded as much as possible to try and get it out of the way. You can see our markers here. My partner trained at UNC, so that kind of looks like the initials UNC. Pre-cannulated the vessels from below, and then we came into the branches. You see this is actually the sheath coming in through the right renal branch, but it kept wrapping around one of the suprarenal stents. So finally, in one lucky pass, it didn't get caught in there, and we got the sheath into the right renal artery, and then deployed an ICAST in that area. I figured an ICAST would do better to maintain some radial force and be able to expand that renal artery. That looked actually great. And in following the technique from the way the P branch is deployed, we remove the sheath, but we keep a buddy wire into that branch and pull it back to keep it close, and then get into the next branch. In this case, you see the SMA, and you see all the collaterals there that go up to refill branches of the celiac trunk. Again, we get the Viaband in place and deploy it, but in this case a little bit short, so we extended a little bit more distally here with an ICAST with a more precision landing than the ripcord that the Viaband has. VBX was not out at this time. Finally, we get to the last renal artery, which you can see is a challenge there with its high-grade stenosis. And also, you see the suprarenal stent coming right across that orifice. So there's double amount of reasons this could not get through. But finally, we get a wire across it, and then the sheath cannot advance into the renal artery because the suprarenal stent is in that area. So we resourced to putting in a balloon from below to force occupying the space, so then the devices have no other place to go but into the vessel. So actually what we did in this case is we inflated the balloon inside the renal artery, and as we deflated, we pushed the sheath in over it, kind of like a watermelon seed, forcing it into that area. And that actually worked quite nicely. We were able to deliver the stent, and then we completed the extension with a spiral Z limb into the pre-existing AUI. And that worked actually really well. The patient had a follow-up CT scan. His GFR actually improved. He went from a CKD 4, almost 5, to a CKD stage 3. Unfortunately, that follow-up CAT scan, I could not get it because it was done locally outside. But I think that in conclusion here, if you have the right tools, you know what you're doing, you have the right inventory and the right equipment, you can handle a lot of complex stuff. But you got to be careful because the gremlins are always out to get you. I'll be happy to entertain any questions. Thank you.